Looking back at the case I just presented, again, I think an important point is to recognize that as a medical oncologist, we are given the luxury of seeing our patients already have been given a diagnosis, either pathologically or radiographically. I think it messages to the primary care physicians that mild symptoms in this situation of being fatigue and anorexia should be warranting a workup and investigation, and appropriately so in this case, including laboratory studies which were normal. Scans did reveal a asymptomatic renal mass. After the patient underwent nephrectomy, one has the opportunity to consider active surveillance, or at times consider the role for receiving adjuvant systemic therapy. Dating back to clinical trials in the probably going about 10 years ago, where initially they looked at the first therapies we had, that being Nexavar versus sunitinib versus placebo. The clinical trial yielded no benefits utilizing a TKI therapy for 1 year after surgery. So too therapies including pazopanib as well as axitinib compared to placebo, both treated individually, meaning axitinib versus placebo in one study, pazopanib versus placebo in one study. And it wasn't until the S-TRACK data was presented several years ago, looking at sunitinib in patients with high-risk features, pathology stage 3, stage 4, and the role for using 1 year of sunitinib therapy versus placebo in patients with high-risk stage 3 and stage 4 disease. Despite the fact that it did meet its primary endpoint, there's been a lot of hesitation in utilizing this therapy. I think the concerns of the risks and benefits of utilizing Sutent for 1 year, utilizing the schedule of 28 days of therapy followed by 14 days off for a total of 1 year. I think this discussion about the toxicities of therapy should be individualized between the physician and the patient, recognizing that in the setting of, in the adjuvant setting, toxicities could potentially be affecting patients' long-term quality of life. And again, despite the data of therapy being potentially benefit improving overall survival by 1.3 years, the concerns truly, of course, about the toxicities of therapy would warrant a conversation between the physician and the patient in regards to the benefits of adjuvant therapy. Moving forward into regards to patients with metastatic disease, once the patient gets initially diagnosed, there are several factors that one takes into consideration when one considers the usage of systemic therapy. The new NCCN guidelines has now made it clear in regards to how we should approach this. I think the most important approach that one should have upon meeting a patient with metastatic disease is actually applying risk stratification. This dates back to the interferon era, utilizing the MSKCC parameters, looking at the time from diagnosis to metastases, performance status, calcium, LDH, as well as hemoglobin. And then more recently, Dan Hang and the IMDC did utilize still those parameters, removing LDH and sort of substituting that for white blood count and platelet count and utilizing a 6 parameter factor in risk stratification. I always tell other colleagues that these informations are all in front of you relatively upon the first visit. The only thing we may not have immediately is the calcium level, but you definitely can utilize the performance status, time from diagnosis to metastases, and the CBC results right in front of you. Risk stratification is part of now the NCCN guidelines, and as a matter of fact, a lot of the therapies we are now using as our first-line therapies for metastatic clear cell renal cell carcinoma is actually categorizing patients in favorable risk categorization compared to intermediate and poor risk. And it is these classifications that the NCCN has updated their guidelines and helpful guidelines in regards to allowing physicians to use as a data-driven approach to how one should consider first-line therapies for patients with renal cell carcinoma. Utilizing the Checkmate 214 clinical trial, it was the first time we actually saw a potential benefit in where we actually see difference in data utilizing a single agent oral tyrosine kinase inhibitor versus combination of immunotherapy. The clinical trial did compare usage of ipilimumab and nivolumab versus sunitinib in patients with intermediate and poor risk categorization as well as favorable risk. The data has been published for, I'd say, 3 to 4 years already. Most recently, Dr. Tanner did present the 42-month analysis. However, we did see that in patients with intermediate and poor risk categorization, there was a significant improvement in both response rates, overall survival, as well as complete responses in patients utilizing ipilimumab and nivolumab. However, in the favorable risk, we do see that single-agent tyrosine kinase inhibitor, that being sunitinib, has continued to show a significant benefit in patients receiving sunitinib compared to the combination immunotherapies. And again, that is in the good risk or favorable risk categorization. So risk stratification to the patients should be done relatively soon because it can determine how one should proceed as first-line therapy for metastatic renal cell carcinoma.